We are live.
A very good evening, everyone. Welcome to the iFocus online lecture 427 of the Cataract module. The topic for today's discussion will be anterior vitrectomy techniques for a cataract surgeon. For the class today, I would like to welcome our moderator, sir, Dr. Prafulla Kumar Maharana, sir. He's finished his MD Senior Residency in Cornea, Cataract and Refractive from RPC AIMS, New Delhi. Sir is an additional professor at RPC Center, AIMS, New Delhi. Sir is also the current secretary of Delhi Ophthalmic Society. Sir is the chief editor of Ophthalmology Clinics, Ophthalmology Clinics 2 and Postgraduate Ophthalmology book series. Sir has published over 395 Google Scholar and 156 PubMed index papers with over 50 chapters in national and international books. Sir has won various awards such as Best Surgical Technique Award from RANSCO, Young Achiever Award from ISCKRS, Ajit Babu Maji Award, the awards for Best Paper in various conferences. He's also the principal investigator in 2 ICMR trials, co-PI in 18 trials, including 2 multicentric international trials. Sir is also a teaching co-in-charge at RP Center since 2016. Welcome, sir.
Thank you, Garvita. First of all, welcome you all. This is a very important topic because this is going to help you throughout your life. If you are whoever becomes an ophthalmologist, he has to perform cataract surgery, and PCR is a part and parcel of that. So no matter how much experienced you are, at some point of time you will land up in PCR and you need to do a vitrectomy. From exam perspective, this may be asked you in Viva questions. At RP Center, we do have a surgical Viva section, or you may get a short note. So please pay attention to the class, and then we'll discuss your questions. Garvita, you can carry on.
Yes, sir. The chairperson for today's session is Dr. Rishi Mohan, sir. Sir is MBBS, MD, DNB, FRCS MAMS. He is the Medical Director and Chief and Cornea Consultant at MMI Tech Institute, New Delhi. Sir has finished his MBBS from Maulana Azad Medical College in 1982 with a gold medal. Sir is an MD Ophthalmology from RP Center AIMS in 1985. Sir also finished his DNB 1986. Sir completed senior residency from RP Center AIMS in Cornea and Cataract. Also, Sir has done fellowship with Project Orbis Inc. USA as staff ophthalmologist in 1989. With a clinical registrarship from Prince Charles Eye Unit, KE7 Hospital, UK. Sir is also part of the Fellowship of Royal College of Surgeons of Edinburgh, FRCS, in 1996. Sir has been awarded membership of the Academy of Medical Sciences in 2006. Sir has numerous academic awards like the Maulana Azad Medical Gold Medal and Certificate of Merit for First Position from Delhi University, the Best Resident Award at the RP Center of Ophthalmic Sciences AIMS in 1986. Sir has also held multiple positions like the member of Scientific Committee of AIOS from 96 to 99 and 2009 to 2012. Sir has also been the Secretary, Indian Society of Cornea and Keratorefractive Surgery from 2011 to 2015. Sir has been a treasurer for Eye Bank Association of India. Also the Joint Secretary from Eye Bank Association of India. Sir has also been the President of Delhi Ophthalmic Society from 2016 to 17. Also the Vice President of ISCKRS 2016 till current. Welcome, sir.
Thank you, Garvita, and welcome to all of you too. Thank you for having me, and I enjoying this iFocus online sessions. We're looking forward to the speaker today is Dr. Hardik, and I'm sure that you're going to introduce him, and we'll carry on from there. Please go ahead.
Yes, sir. Dr. Hardik, sir, is the speaker for today, sir. He's finished his MBBS from Gujarat Adani Institute of Medical Sciences from Bhuj. He's finished his MS Ophthalmology from Gitanjali Medical College and Hospital in Udaipur. Sir has also finished his fellowship in retina surgery from the LV Prasad Eye Hospital in Hyderabad. Sir is currently working as an associate consultant at Center for Sight, New Delhi. Sir has published various papers in national and international journals and presented various presentations at national and international conferences. Welcome, sir.
Thank you, Garvita. Thank you. Thank you for your kind introduction. Just let me start my screen sharing. Is it visible now?
Yes, sir. Yes, sir, it's visible. Your screen is not visible, sir. The presentation is not visible, sir.
Can you see
Yes,
it?
it's visible now, sir.
It's visible now.
It's in full screen mode, right? And the
Yes, sir.
slides are moving.
Yes, sir.
Okay. So thank you, everyone, and good evening. So myself, Dr. Hardik Kiri, I am going to present a class on anterior vitrectomy techniques. And first of all, I will like to thank Team iFocus for giving me this opportunity. So in today's class, just if I will briefly overview, so we will first discuss the case scenarios. So in which cases we can have a posterior capsular rupture and what are the signs we can identify the PCR. We will see a different video clips that we can identify and how can we manage those things. What are the parameters we should keep while doing the anterior vitrectomy, how to manage a PCR and how to follow up those patients and how to counsel such patients. So this is the way we will discuss our today's class. So I don't have any financial disclosure for today's class, and these are the abbreviations you might find during the presentation. So first of all, we all know that we require anterior vitrectomy when there is a vitreous loss. So vitreous loss can occur when there is a posterior capsular rupture, or even it can occur in cases of zonular dialysis, or when while during the cataract surgery, if the lens come out with a whole bag in toto. So in such cases also we will see a vitreous loss, and in those cases we require anterior vitrectomy. So these are some of the list of the cases which are having a higher risk of having PCR, and some of them are small pupil in cases of high myopia, pseudoexfoliation, traumatic cataract, white cataract or hard cataract, vitrectomized eye, or a posterior polar cataract. So reason why I am discussing this etiology here, because we will come to know and we will be prepared prior taking those cases. And at your one command, the anterior vitrectomy should be available. A three-piece IOL should be available, especially when you are taking this kind of high-risk cases. And when you are in your training period and you are struggling with the normal cataract cases, then it is better to avoid such cases in the early training period. Once you are confident enough, you can shift to these cases. And one more thing, how to achieve a zero PCR rate. So there are two situations when we can achieve a zero PCR rate and 100% success rate. If you are relaxing and not doing a cataract surgery, or if you are a Lord Krishna. So in my knowledge, I think there are only two conditions where you can have a zero PCR rate. But otherwise, to the normal people, I will say that at some point of time in your life, you will definitely get a PCR if you are doing a surgery. And always have a good observation and develop a good surgical skills, so you will able to identify these things earlier. Whenever the complications happens, you can identify it and you can avoid a potential further upcoming complications. You can manage the case immediately. So these are some of the signs where which indicates there is a posterior capsular rupture, like a sudden deepening of anterior chamber, a pupillary snap. So some of the signs we will discuss in the videos also, but here I have listed those things. Or previously, if there is a mobile nucleus and now it's not mobile, like you are able to remove some quadrants of the nucleus, but now you are not able to even shift those nucleus parts, or even you are not able to emulsify those nucleus parts because the vitreous fibers have came into the AC and that are blocking your phaco-tip. And when your phaco-tip is even not occluded with the nucleus fragment, but still it is showing the occlusion sound, then also it triggers that there might be a PCR and there is a vitreous in front of your phaco-tip. Tilting or descent of nucleus or suddenly disappearing of the nucleus. Pupillary peaking, when you have started the surgery, the pupil is very round and regular, but suddenly you observe that pupil is peaking somewhere, then it might possible that the vitreous strand is there, which is causing this kind of problem. Tilt of nucleus or star fold over the posterior capsule or unusual clear spot. The meaning of unusual clear spot is the sudden appearance of a red glow, because there is a no PC, so suddenly a fundal glow will be appear, which is a bright red and which is as a sudden appearance of a red glow. This is also indicating of PCR. So wound is not sealing despite of proper construction, because the vitreous fiber will not allow to closure of the wound, a visible posterior capsular tear, or a presence of vitreous in the anterior chamber. So these are the signs which will tell you that there is a PCR. And if you observe those signs early, then better, because this will lead to less complications. and better management. So if any point of time you observe of any of the above mentioned signs, then what should be your next step? So many of the time we are having this question that once we observe the PCR, what is the first thing we should do? So I feel that the first thing is that don't get panic, because PCR can happen any point of time, but don't get panic. Be calm and have some patience. Don't suddenly remove the instruments from the eyeball. Keep the instrument inside the eye only and stay in the foot pedal position 1. So it will maintain the flow, maintain the globe. It will not allow the AC to collapse. And gently remove the second instrument and put a dispersive viscoelastic over the posterior capsular rupture and in the anterior chamber. So it will maintain the AC and it will not allow the vitreous to come into the anterior chamber, and decrease the bottle height. Usually, depending upon the parameter which we have set, and depending upon the machines, our usually bottle height will be around 80 to 110 centimeters. So ask your technician to decrease it to the around 25 to 30 centimeters and gently put the viscoelastics and then gradually remove the phaco tip. During this procedure, if you observe that your nucleus is shrinking in the vitreous cavity, don't do fishing, let it shrink down. Because by fishing, you are going to cause more traction over the vitreous, and which will lead to pulling of the vitreous and cause retinal detachment or retinal break. So don't do fishing. If you observe any kind at any point of time PCR, be calm. Remove the second instrument, put a dispersive viscoelastic over the posterior capsular rupture and in the anterior chamber, and then gently remove the phaco probe. Keep your bottle height low. So this is how we should go ahead. And your next step should be to ask your technician or your assistant to arrange an anterior vitrectomy. So this is one surgical clip of our fellow. I think there are a lot of learning point in this small video clip, and I will like to just make sure that all the viewers are watching this clip and they are not going to miss any of the point here. So I'm going to play this clip 3 times. First, let us observe just, I am not discussing here anything. And then we will see that what are the other things which we can observe here and which could be had done better. I think that most of us has realized that there is a PCR. So just let us discuss it again. I'm going to play it again. So here we can see that the surgeon is trying to divide the nucleus into 2 parts, but the surgeon is not able to do it. So he plans to further deepening of the trench. So while deepening of the trench, we can see there is a sudden constriction of the pupil. If you can see here the pupillary margin, and if you observe prior, then the pupil is large enough here. But suddenly, the pupil has become small, and suddenly the AC is also getting collapsed. So this thing is called as pupillary snap. So why the pupillary snap occurs? Because there is a sudden equalization between the anterior and posterior segment pressure. Usually the anterior segment has a more pressure than the posterior segment, but because of the PCR, the fluid is moving behind. It is going into the posterior segment and the pressure become equal, and that's why the pupil becomes shallow and there is a pupillary snap and the AC becomes collapse at small friction and during this small friction of time. So here you can see that pupil is well dilated. Now pupil has become small. And if you observe again, the nucleus has shifted towards the one side. In the starting of the surgery, the trench is in the center. But after that, now if you observe where the trench has moved, it has shifted towards the left side. You can see here suddenly there is an appearance of red glow. Just let me go it again. So if you can see here, the red glow is there, but in this part of the area, you can see a bright red glow because there is no pupillary, there is no posterior capsule there. So this thing is called as a sudden appearance of a red glow. So in this case, we have observed there is a pupillary constriction, pupillary snap sign. There is a shifting of the nucleus. There is a sudden appearance of the red glow. And good part is that our fellow has realized this thing at the very appropriate time. And he has not removed the instrument suddenly from the eye. And this is, I think, the best thing. At this point of time, you should have gently remove your second instrument, keep your bottle height on the lower side around maybe 30 centimeter, put a dispersive viscoelastic over the area of posterior capsular defect and in the anterior chamber, and then gradually remove your phaco probe. So this is another video clip. This is a video clip of mine only, which I have done during my phaco training days. This was hardly my second or third case of phaco. So you can see here that I have removed the nucleus very well. I was able to remove the cortex on the one side, but there is some cortex left on the other side. Maybe by this time I was a little bit of overconfident and very aggressively I was approaching to remove the cortex. So if you have observed here also you are able to see the pupil and the iris. But in the starting of the case, there was a very small little bit of iris visible. So the pupil was very well dilated. But at this point of time, the pupil has become a little bit small. The cortex, which was not visible very easily, is now very easily, which is visible very easily. At this area, you can see there is a bright red glow. So there is a posterior capsular defect, which I was not able to identify. And still I was approaching to remove the cortex. And the cortex is not coming because the vitreous is there, but I was not able to identify those things. And without further pulling will lead to increase in the diameter of the posterior capsular rupture. And when at this point of time also I was not able to remove the cortex, I realized that yes, I have created a big mistake. But yes, this is how we learn. So the PCR can occur at any point of time, at any step of the surgery. It can occur during your hydro procedures as well, particularly if you are doing a hydro dissection in a case of posterior polar cataract, or even when there is a posterior and when your capsular rhexis is very small and you are doing a very aggressive hydro. So at that point of time also the back pressure can increase and it can lead to rupture of the posterior capsule. So now we will discuss that how to further manage such things. And there we all know that there are two modes available for the vitrectomy: cut IA mode and IA cut mode. Some of the times the people have confusion that what are the exactly the modes which we need to use for the anterior vitrectomy. So just let's discuss those things first. So first of all, in cut IA mode, we all know that there are 3 foot pedal positions in your foot pedal. The first foot pedal position during this mode is irrigation. Once you will press further and you go into the foot pedal position 2, your cutter will start. So it is irrigation plus cutter. And when you foot pedal press fully, then the aspiration will also start. So in foot pedal position 3, there is irrigation, cutting plus aspiration. So this thing is useful when you want to cut the vitreous and you want to do anterior vitrectomy. Because what is our aim is that to remove the vitreous by cutting into small pieces. We don't want to aspirate it, we don't want to pull it. So we are cutting the vitreous into small pieces, small fragments, and then we want to aspirate it. So we use a cut IA mode. Another mode is a IA cut mode. In IA cut mode, the foot pedal position 1 is same, which is irrigation. If you further press your foot pedal and go into position 2, the irrigation and there will be an aspiration. And when you go into a foot pedal position 3, there will be irrigation plus aspiration and then cutting. So this kind of mode is helpful when you want to remove a cortex, because you are first holding the cortex, you are pulling it and losing it, and then you are removing it. So this is how it's useful. So these are the parameters which usually we keep in our machines. So during the cut IA mode, when you want to do an anterior vitrectomy, whatever highest possible cut rate is there available in your machine, you can put it. Like in Laureate machine, the highest cut rate is available is 1500 cuts per minute. In Infinity is around 2500. But in newer generation machine, there are very excellent cut rates available, which are around 4000 or 5000 cuts per minute. So while doing the anterior vitrectomy, put your cut rate at the highest available in your machine. And in IA cut mode, the cut rate should be on the lower side, because the part which you are now removing is either a small lenticular parts or a cortex or an epinuclear plate. So for that, you need to put the cut rate on the lower side, which is around 200 to 300. So once you are now, till now, we have learned that what are the signs to identify the PCR. Once you have identified the PCR, what are the next step you should do? And now we will see that what are the techniques available to do the anterior vitrectomy. So once you have noticed that there is a PCR, it is always better to stain it with a triamcinolone. So triamcinolone usually stains the vitreous fibers and it will attach to those fibers and it will not move. So it will give you better visualization of these things. It is always better to dilute the triamcinolone. Dilution can be with a 1:4 or 1:10 with your basal salt solution or a normal saline or a ringle lactate solution. Avoid to putting over excessive triamcinolone because it can again obscure your view. Here we can see that after putting the triamcinolone, the surgeon has washed it. So whatever free triamcinolone these particles were there, they have came out. But the particles which are now in contact with the vitreous fiber, those fibers are stained with these particles. So it will give you better visualization of the vitreous. And avoid putting excessive tricot because it can go behind also from the posterior capsule rupture. It can go into the posterior segment and the patient will have a floaters, and in steroid responders, it can increase the intraocular pressure. So now the surgeon is planning to do a bimanual vitrectomy. So this is the cannula from which the fluid will come inside. And this is the cutter. We can see the opening is moving. The fibers are very nicely, they are removed by cutting it. Here the cut rate is around 2,500 cuts per minute. From over the posterior capsular dehiscence, the surgeon is removing the vitreous by putting the opening of the cutter beneath. And here also we can see the stained vitreous is there, which the surgeon has removed very nicely. Make sure that your irrigation cannula is staying inside the anterior chamber and don't direct your irrigation cannula over the posterior capsular rupture because the fluid can go in the posterior segment, which will again lead to increase in the pressure in the posterior segment and more vitreous will come on prolapsing. So your infusion cannula should remain in the anterior chamber or it should be directed towards the angle. And just stay at the posterior capsular rupture, the vitreous will itself come into the vitrector and you will able to do the vitrectomy. And the remaining vitreous, you have to move your vitrector and you can cut it. If there is any pupillary peaking, then also you can identify that there is a pupillary peaking. So possibly there is a vitreous there, you can remove it. Another thing is that a swift test. So you can use a blunt instrument for that. Here the surgeon has used iris repositor. So just swiping in the anterior chamber, we can observe that by moving it, the vitreous fibers are also moving. I'm playing it again. So surgeon is moving the blunt instrument and just observe here, the fibers are also moving. So which is giving us a clue that yes, definitely there is a vitreous there and we need to remove it. So this is another way of identifying the vitreous. Just make sure that you are not pulling it too much because it can again cause traction over the retina because these fibers are attached more commonly on the ora serrata and it will lead to pulling there. Another thing which we can do is a gentle bird test. So you can put a Johnson bird over a side port and gently just touch there. If there is a vitreous fiber is there, then it can also lead to moving of the vitreous fibers. But that thing should be avoided because that can lead to again pulling. So I think the best ideal thing is to put a triamcinolone in the anterior chamber or do a gentle swipe test. So here we have, in the previous cases, we have seen that surgeon has used infusion in the one hand, irrigation cannula in the one hand and the cut vitrector in the other hand. The another option left is the putting the anterior chamber maintainer. So this is a case of ectopia lentis where the lens was removed in toto with the bag and the glued IOL was planted. So a scleral tunnel was made. An anterior chamber maintainer is put here and the surgeon is removing the anterior this vitreous which is prolapsed with the cutter. If you can notice that there is a pupillary peaking here, so which is giving us clue that there is definitely vitreous there. Surgeon has first removed the vitreous which is there in the scleral tunnel. Then gradually we are cutting the vitreous which is available in the central part. At every point of time here the cutter opening is facing towards the cornea And once the surgeon has removed the vitreous fibers from that pupillary peaking area, the pupil has become round. Just one thing which can be done here was that to make a side port and to introduce the vitrector from the side port, which will allow you better stability of the anterior chamber. But this is also a method where the surgeon has approached through the scleral tunnel. And the another thing which we have discussed was a IA cut mode, so which is useful to remove the cortex. So here we can see that the capsular rhexis is very nicely made. On the one part, the cortex is very well removed, but in the some part there is still cortex left and there is a large posterior capsular rupture there. So surgeon is approaching with a bimanual technique. There is a irrigation in one hand, and other hand we are having the cutter. So just I will like to just again reinforce that while we are in this center, our foot pedal is in the foot pedal position 1. So basically irrigation is ongoing from this instrument. This fluid is coming in the anterior chamber, but our cutter is not working at this point of time. It is stopped. So once we are going into the periphery and once we are near the cortex, we are tracing the foot pedal. We are going into the foot pedal position 2. And here the foot pedal position 2 is the aspiration. So we are holding the cortex. We are loosening it up. And once we are able to lose it, we are pressing it further foot pedal, and which is foot pedal position 3, which is cut. And we are able to remove the cortex. So this is how the IA cut mode is useful to remove the cortex. When we are in the center, we are foot pedal position 1. When we go into the periphery, we are pressing it further in foot pedal position 2. When the cortex is loosened, we are pressing further foot pedal to remove the cortex. One another use of the low cut rate is to make a PI. So if you can see here, the cutter opening and closing is very well visible. This is hardly at 200 cuts per minute. In some of the cases nowadays, we don't very frequently use is this AC IOL. But whenever we all know that we need to implant AC IOL, or in some cases where we want to do a PI, we can use a cutter to do a PI. So here the cut rate is hardly 200, and we are going into the periphery and we are just pressing the foot pedal and we are seeing that very nice and controlled PI is made. So this is also one of the use of the cutter, that to make a PI with a low cut rate. Another approach is pars plana vitrectomy. In most of the cases, the anterior vitrectomy is sufficient if we are doing it from the side port or from the scleral part. But in some of the cases where the nucleus fragments are more shifted towards posterior part, or we are not able to remove the cortex part or even the nucleus part, a pars plana approach can be done. Here we have put the trocar in these cases, but the trocar, if not available, just you can do a localized peritomy, and around 3.5 mm far from the limbus, you can enter with a 23 gauge MVR, and then you can introduce your vitrector. And instead of infusion, like in this case, you can use the irrigation cannula from the side port. So that is also another option available. So once you are sure that you have removed the vitreous from the anterior chamber, now you have to assess that what kind of IOL you can place. So in this particular case, there is a large PCR we can see here. The surgeon has done very nice, beautiful anterior vitrectomy, so vitreous is not there now. But we can see a beautiful capsular rhexis is there, which is round and very central. So here the surgeon has planned to put a 3-piece intraocular lens into the sulcus. So depending upon the situation, you have to plan for the intraocular lens implantation. You can do a pupillary capture there, and always put a suture over your wound, because by putting the suture, your wound will not leak and definitely chances of infection are also less. Particularly if there is a second surgery is planned, in case of where there are nucleus fragment or nucleus which has dropped, or if the patient is aphakic or there is an IOL drop where the second surgery is planned, might possible there may be a need of again to give a peribulbar block or something. So while giving the peribulbar block and while doing the massage, the pressure can get raised and your old wound can open. So always better to put a sutures in cases of complications, or when there is a posterior capsular rupture, when there is a nucleus drop, when there is an IOL drop, or when the patient is aphakic. And once you have put the IOL, once you have done the proper vitrectomy, always recheck that the vitreous is not there. So here, after putting the IOL, all the vitrectomy is done. Again, before closing the case, the surgeon is putting the diluted triamcinolone in the anterior chamber, and to reassure that there is no vitreous is there in the anterior chamber. So after putting the triamcinolone, we have to just gently wash it, and all the free particles will come out. If there is a vitreous is there, then the vitreous will get stained with the triamcinolone particle and it will not easily come out. So this is how we should go ahead and we should manage the case. So once you are done with that, on the post-operative follow-up, it's always necessary to check the peripheral retina to see for if there is any kind of traction is there, if any kind of nucleus parts are there, or to look for the retinal detachment. Might possible on the post-operative day 1, there may be a significant corneal edema and the fundus might not visible, but you can see it after 3-4 days or within a week. Monitor the IOP closely because excessive use of viscoelastic substance can cause increase in the intraocular pressure, or sometimes there may be hypotonia because of the vitreous loss, and you have to manage it accordingly. In the post-operative medications, topical antibiotic and steroids should be used. We also use NSAIDs because there is a dehiscence in the posterior capsule, so inflammatory mediators release in the posterior segment as well, and which can lead to formation of cystoid macular edema. And to control the intraocular pressure, you might need to give anti-glaucoma medication. And if there is an inflammation there, then cycloplegic drops are needed. And another important point is always discuss this thing with your patients. When your patient is satisfied, I think your half job is done. So always tell the patient and the relative that there is a complicated case was there, and which might need frequent follow-up and long-term medications. And most of the patients will do well. If you think that the patient is aphakic, or if there is a IOL drop or nucleus part has dropped, then always guide them that the patient will require a second surgery. Guide them to a retina surgeon. Have a good rapport with retina surgeon, because it's your job further to guide them what is the best thing to be done. That now it's patient's choice if they want to have a second opinion or third opinion, but it's always your job to guide them the proper thing. And warn them there is a possibility of floaters post-surgery. So just before I will like to conclude that even in the experienced surgeon can have the complication of posterior capsular rupture. The main thing is to not get panic, and most of the cases can managed very well with a good outcome. And PCR can cause a stress, but its stress can be minimized by a right patient selection, mental preparation, and recognition of the earliest sign, so which will lead to further complication and early management. Assure that all the instruments are available, the vitrectomy is available, 3-piece lens is available, and at your one command, all the things should be available, and your technicians should be also well trained in such cases to manage the things. I will like to thank my seniors and my colleagues for helping out with me giving the video clips. Thanks to Dr. Gaurav, Dr. Kanika, and Dr. Kritika. Thank you, everyone. So now I will like to just open this presentation for discussion further.
Thank you, Kiri. Thank you, Dr. Hardik. Thank you. Is Praful here? The moderator is here.
Sir is there in the panel, sir, but I think there's some audio issue probably.
Right. So I must say that it's been an absolutely has he left? Okay. So who's going to be moderating in Praful's absence, Garbita?
I'll do it, sir. No issues. I'll do it.
So anyway, let me just make a few comments. I think it was brilliant. Very nice talk. You covered it so comprehensively. And one thinks that if there is vitreous in the chamber, one can just, push in a vitrector and just do what one feels like. But as you've rightly shown, you've gone through the whole process of showing us how to recognize a PCR. because that is usually the commonest time that an anterior segment surgeon is going to encounter vitreous. It's unusual to have, I mean, one can have traumatic cataracts and subluxated lenses and ectopic lenses where vitreous is already in the chamber. But on the whole, sometimes the presentation comes as a surprise. And one has to be prepared. And I think you very rightly mentioned about altering the normal settings on the vitrector, which is to put cut before you suck. So that is very important. And how you also highlighted that if it's cortex you're dealing with, or for that matter, if you're dealing with epinucleus or even nuclear fragments, then you're better off having aspiration first and then cutting, because you need to bring the piece to the port before you can actually chop it. So that is important too. On the use of triamcinolone, I think it's a brilliant innovation of being able to put triamcinolone into the anterior chamber very lightly and a very little bit, so that it doesn't go too much to the back. It does absorb eventually, but yes, initially it can give rise to a little bit of issues with visibility, as well as give floaters, and also give rise to an IOP rise in susceptible individuals. The triamcinolone, it's good not to shake it before you withdraw it from the vial. You're better off taking a needle and getting only the powdery material and less of the fluid, and then diluting it with BSS. And the reason for that is that this is a preserved medication. It contains a preservative. It is not really meant for intraocular use. And when you take a vial of Kenacort or one of these triamcinolones, then you're better off letting it stand and allowing the supernatant not to be sucked in, and going to the bottom and withdrawing only the powdery material, which is what we need, right? The pars plana approach is also brilliant, and one can sometimes not get a good cleanup with just the front area going through the anterior segment, and so one must be prepared to have a pars plana approach ready. You mentioned about the cut rate, and my feeling is that if you just have a phaco unit with an attached vitrectomy, anterior vitrectomy, I doubt if it goes to 2,500 cuts a minute, because many of these machines are not equipped to do that. But yes, the higher the cut rate that you can achieve, the better off you are with the safety, as far as not allowing too much of traction on the vitreous. So I think those are my comments. Really getting a pupil down, I think in the end, a little bit of a miotic should be instilled. It does two things. One, it ensures that you get a round pupil. Two, it tells you whether there is peaking. If there is peaking, which you may have missed, there may be a small strand lying along the iris, which you may have missed. And that part, the pupil will remain little distorted, and letting us know that there is a little bit of vitreous still in the chamber, which needs to be dealt with. I think that's pretty much about it. I think you highlighted the point about suturing, which was brilliant again. Many of these patients will need another intervention, and one cannot be, the wound cannot be secure if it is left, at least in that size, without at least one or more stitches to secure it. So I'll hand it back to you, Garvita, to carry on with the discussion. I'm sure there are many questions and many things that must have come up on this topic. So please go ahead. And thank you so much, Hardik. It was a wonderful presentation. I enjoyed it.
Thank you, sir.
Thank you, sir. I'll just share a few questions that we have in the chat box. Number one, doesn't it increase risk of tractional retinal rupture if we remove manually the vitreous fibers?
So basically, we need to always go ahead with the automated vitrectomy. In most of the vitrectomy, in the phaco machines, we have the vitrectomy settings there, and vitrectomy is available there. So whenever we are performing the cataract surgery, always make sure that the vitrectomy is working in those machines and vitrector is available. If these things are not available, then I think that you should not do the cataract surgery there. Another point, I will feel that in many of these scenarios might possible that there is only one cutter is available and the cutter is not working. So in such conditions where there is no option left, I think that is the last option that you should go with the manual vitrectomy, which is with the scissor, because it will create a more pull. It will create a more pulling of the fiber of the vitreous and it will lead to more distraction over the retina and it can lead to break over the retina. So always make sure that the vitrectomy is working wherever settings you are doing the phacoemulsification or the cataract surgery. In case at the end moment, if the cutter is not working, then I think it's better to have some vitrectomy with manual method instead of just closing it or just putting the sutures in the, and your vitreous is still there over the wound.
Right, sir. We have other questions. What medications to be prescribed post-operatively? Any special considerations, sir?
I think that thing we have already discussed, nothing special, but yes, the topical steroids and antibiotics, we use the topical steroids in most of these cases, the inflammation will be little bit on higher side in compared to the normal conventional cataracts, which we do. So frequency of these steroids is usually on the higher side, maybe around 2 hourly. We will start in the immediate post-operative period. If there is a significant inflammation is there, then we need to give a cycloplegics. And one more thing which we add here is a NSAID eye drops. Because there is a dehiscence in the posterior capsule, so definitely there is a communication between the anterior segment and posterior segment. The inflammatory mediators will release into the vitreous cavity, which can lead to a CME or cystoid macular edema formation. So to reduce the chances of CME, we are giving NSAIDs in such cases. And if the IOP is on the higher side, as we have discussed, we need anti-glaucoma medications. If there is a hypotonic, then definitely you will have to give the steroids in higher frequency.
The
Right,
other
sir.
thing, Garvita, that I would add is many of these surgeries which have not gone as planned, and we have a lot of handling in the anterior chamber, they can come up with a substantial amount of corneal edema as well. And one may be prepared for a significant amount of folds and desymatitis, and there a hypertonic saline addition may also be useful. But otherwise, I think he has completed the list perfectly.
Right, sir.
And always, I think it's better to explain the danger sign to the patients. Danger signs in terms of endophthalmitis, because these cases are having higher risk of endophthalmitis. Always explain them if there is a sudden increase in the pain, if there is a further decrease of the vision, or if there is a periocular edema, then report to you immediately. Because these cases are having higher risk of endophthalmitis, and we don't want to again delay such complications if the such things happens.
No, I think you beautifully put up that slide about communicating to the patient. And I think patient satisfaction is not just getting a good job done, but also being able to tell them what is happening. And these patients are not only at higher risk for end-off, they're at a higher risk for many other things, right? From corneal decompensation, IOP issues, lens luxation, subluxations, CMEs, detachments. So it's the list, the moment you disturb the posterior segment, the list becomes much, much longer. I think communication is a very, very important angle to that. Go ahead, Garvita. Next.
Yes, sir. Next question is how to dilute the triamcinolone acetate, sir.
I think sir has very beautifully explained those things. So just as sir explained that don't shake the bottle, take these particles from superior part only. And the dilution with the BSS is around 1:4 ratio or 1:10 ratios, depending. You can dilute it.
Some people actually prefer to let it stand and let the supernatant appear. It's a suspension. So the powder settles to the bottom, the supernatant comes to the top. If you keep it in the inverted position, when you aspirate, sometimes it's easier for you to get the powder only and let the supernatant stay away. You can put it into another vial if you're very, very careful. Like I recall reading a study about it some years ago, where you could actually put it in another vial with the irrigating fluid and again allow it to settle. And then again pick it up from the bottom. So you've got two supernatants, like a wash in a sense. So you get pure powder with very little fluid and very little preservative. So that way it's less toxic. But I think from a practical standpoint, really the amount you need is probably 0.05 or 0.1 ml is all that goes into the anterior chamber for you to be able to do the job. And more dilution than 1:4, I don't think is really required. Is that your experience, Dr. Hardik?
Usually we dilute it as a 1:4 only, but yeah, some of the surgeons prefer to dilute it as a 1:10. But in center for sight, usually we dilute it as a 1:4.
1:4.
So the next question is there any restrictions you advise to the patient to follow post-operatively?
I think there is no any specific thing. Routine post-op, which precautions we advise, those are the simple advice, nothing specific related to PCR.
Right,
I think
sir.
the only thing that one must explain to them is not to be over expectant. People want that the patch comes off and they are looking at 6/6 vision. And even in well-done surgeries, that's sometimes or very often not the case. But in patients who had a disturbance of the vitreous and so on, especially if you've left them with a cycloplegic, with a fair amount of corneal edema and all that, they're unlikely to develop very good vision. And that is the one thing you must counsel them, because the first thing they're going to come and complain to you next day is that they can't see. So if they're already forewarned and we've been told about it, their expectations become more realistic. Other than that, no specific precautions other than the conventional that you would give for any standard surgery.
Yes, sir. So the last question is there a different strategy according to the size of PCR? What is your experience with it, sir?
Not regarding the size of the PCR, but definitely your management can change depending upon the presence or absence of the vitreous. Many of the time might possible the PCR very small and there is no vitreous loss. So in such cases, there is no need to do a vitrectomy. By doing that thing, you may increase the size of the PCR, or even you can pull the vitreous, and if the vitreous is not there in the anterior chamber, you are inviting them to come into the anterior chamber. Thus you can go ahead with your IOL implantation, you can close the surgery. But if there is a vitreous in the anterior chamber, then definitely you need to do a vitrectomy. Just make sure that the PCR will not further enlarge in the size by making sure that you are not pulling the vitreous, by making sure that what is the highest cut rate available in your vitrectomy machine, you are putting it at the highest cut rate available. And one more thing I have seen sometimes that you can put some of the people try to put an IOL first and then do a vitrectomy, or to wash to remove the cortex. So which will give a kind of scaffold the IOL will provide and the vitreous will not come forward. But it depends on case to case. If the axis is properly round, it is available. And if you are able to implant the intraocular lens, then you can do it.
So on that pretty well sums it up, but I would only add a couple of things. One is that the size of the PCR does matter, because one may still go ahead and put an in-the-bag implant. One doesn't necessarily have to use epilenticular or put a sulcus lens or a 3-piece lens. One can still go ahead with the implant, but one has to ensure that the angle at which the haptics go in are safe and secure. The other thing one has to see is that there is no vitreous in the chamber and in the posterior inside the bag either. One of the things that's important to remember here is to try and not allow the anterior chamber to shallow. I think you highlighted that at least twice or thrice in the presentation, that the moment you do that, the vitreous from behind is going to make that opening much larger. And one of the things to do is to use a dispersive viscoelastic, and that's important. Don't use Heal-On or a cohesive viscoelastic. What that will do is that it mixes with the gel, and one then cannot tell whether it is vitreous that you're dealing with or Heal-On that you're dealing with. So if you try and use a spatula or an instrument, in vitreous you will see movement. In Heal-On, you'll see the same movement. In a dispersive viscoelastic, you will not. And so that is where there is value to use a dispersive in such patients and not use something more cohesive. So one can get away with a nice round opening. One can also take a small PCR and actually convert it to a PCC. If you have if the chamber is well deepened, and one can actually convert the posterior capsular rent into a small, more secure oval, or a slightly. I mean, it may not be round, but as long as it's complete and you don't have edges running out, that's a secure PCC, and you can put an in the bag lens in those patients.
Right, sir. So these are all the questions that we had today. Any other inputs for the class?
I think one point I would like to make, that complications can occur to anyone or any point of time, and might possible that the things will not go in the way you have planned. But one thing you can always do is that you can stop at any point of time. If you think that the things are not going the way as planned, just don't complicate the thing much. And you can close it at any point of time. You can take the help of your seniors, your colleagues, you can refer to the patient, because not harming much is also you are giving something good to the patient here. That's the one thing I would like to say.
Very
Spoken
valid.
like an experienced surgeon, Hardik. I appreciate that. Knowing when not to fiddle is actually an extremely, sometimes very difficult, because you think you can do it. You think you can get that piece out. You can't. It's going to go back. So unless you had the experience of doing that, it's better to just stop and not do too much damage. There was a time going back 15 or 20 years, I would be, or even longer, I would worry about putting a lens, and I thought that putting a lens is better to leave the patient aphakic and then do the vitrectomy and this thing at a later stage. But now I think with all the betterment in the equipment and all of that, there is really no problem. As long as the anterior chamber has been cleared of vitreous, one can put in the lens and still refer the patient for a posterior approach in case there is any stuff that has fallen back and needs to come out. Great.
Thank you.
So thank you, Dr. Hardik sir, for a lovely class. It has, I think, covered all the aspects that a young beginner surgeon can deal with intraoperatively. Thank you, sir, Dr. Rishi sir, for your valuable inputs. And I think we can finish the class now, sir.
Thank you, Kavita. Thank you, Rishi sir, and thank you all the listeners. Thank you.
Thank you so
Thank you,
much, Dr. Hardik. And thank you, Garbata. It's been a
Thank you, sir.
wonderful evening and a lovely iFocus session.
Yes.
Thank you.
Thank you, sir.
Thanks. Bye.